everyone. Today's my topic presentation. Before going directly to the topic, I would like to give a short introduction. Imagine that you are in the trauma bay receiving the patient with a sustained trauma. Emergency medical responders sign out to you that the blood pressure has been fine on the way, 110 over 60 mm of Hg with the heart rate of 60 beats per minute. As you complete your primary survey and get the patient on the monitor, you find the pressure has dropped drastically, 80 by 50. But rather than tachycardia, the patient's heart rate is only 45 beats per minute, and the rhythm on the monitor is sinus bradycardia. The hemoglobin on your initial lab is 14.4 gram per dl, and there is no clear source of blood loss. With this introduction, I hope you are able to guess the topic, or you may be still confused. Without wasting much time, let me reveal the topic. Today, I'm going to present about neurogenic shock. So, most often, neurogenic shock is an under-recognized but deadly cause of hypotension, bradycardia, and other complications related to spinal injury. In this presentation, we will see in detail definition, incident, types of shock, causes, pathophysiology, signs and symptoms, diagnosis, management of neurogenic shock, and conclusion and summary. What is neurogenic shock? Neurogenic shock is a distributive type of shock. In neurogenic shock, vasodilation occurs as a result of loss of balance between parasympathetic and sympathetic stimulation. It is a type of shock. It is life-threatening medical condition in which there is insufficient blood flow throughout the body that is caused by sudden loss of signals from sympathetic nervous system that maintain the normal muscle tone in blood vessel walls. What are the statistics and incidences? How common is neurogenic shock? Studies estimate that 19% to 31% of people with a spinal cord injury get neurogenic shock. Each year, about 8,000 to 10,000 people in America injure their spinal cord, mostly through car crashes and falls. The data obtained from Trauma Audit and Research Network after a comprehensive analysis of around 490 isolated spinal cord injury cases found that only 19.3% cases involved in typical neurogenic shock. There are no universally defined hemodynamic parameters for neurogenic shock. What are the causes of neurogenic shock? Neurogenic shock could be caused by many following reasons. Mainly spinal cord injuries, recognized cause to hypotension and bradycardia leads to neurogenic shock. Spinal anesthesia, injection of an anesthetic into a space surrounding the spinal cord, or severance of spinal cord results in a fall in blood pressure, cause of dilation of blood vessels in the lower portion of the body, and a resultant diminution, which is a decrease of venous return to the heart. Sports injuries related to trauma to the spine, inaccurate administration of anesthesia to spinal cord, road traffic accidents leading to spinal cord injury or damage to the central nervous system. Antidepressant medications and lack of glucose could be a cause of neurogenic shock. What are the types and subtypes and hemodynamic changes? Distributive shock, we can see this kind of shock in mainly septic and anaphylactic and neurogenic shock. There will be a variable cardiac output and decreased SVR. And cardiogenic shock, SVR is systemic vascular resistance. So cardiogenic shock is a myocardial infarction, cardiac arrhythmias, valvular pathology, and heart failure. Again, we'll see here decreased cardiac output and increased systemic vascular resistance. Hypovolemic shock because of hemorrhage, burns, gastrointestinal losses, again decreased cardiac output, increased SVR. Obstructive pulmonary emboli, tamponade, pulmonary tamponade, emboli, tension pneumothorax. And again, we see decreased cardiac output, which is common in all types of shock because of poor perfusion, and increased systemic vascular resistance. So what are the difference between spinal shock and neurogenic shock? So the definition of spinal shock is it is a transient loss of reflexes and sensory motor function below the level of the injury. And in case of neurogenic shock, it is a loss of sympathetic tone with unopposed parasympathetic control, leading to cardiovascular instability. Blood pressure in both types of shock, it is hypotension, heart rate will be bradycardia. Then associated autonomic symptoms in case of spinal shock, difficulty breathing, bowel and bladder dysfunction. And in neurogenic shock, we can see autonomic dysreflexia, orthostatic hypotension, and there will be temperature alteration or irregulation. Motor, mainly flaccid paralysis in spinal shock, and in neurogenic shock varies with the injury. Reflexes mainly in spinal shock, we can see areflexia or hyporeflexia in early stages, hyperreflexia in later stage of resolution. And in neurogenic shock varies with the injury. The duration approximately in spinal cord injuries, it takes days to months, and in neurogenic shock, mostly often 1 to 6 weeks, that is in the acute initial stage. Treatment, stabilization in case of spinal shock, it's stabilization and treatment of underlying injury. And neurogenic shock, it is fluid and vasopressors with appropriate temperature monitoring. Moving on to pathophysiology. So damage to the brain and spinal cord leads to loss of sympathetic tone. When there is loss of sympathetic tone, parasympathetic nervous system is unopposed. It is a defense mechanism. So leading to uncontrolled vasodilation and decrease in the low blood pressure will fall. And as a result of blood pressure is low blood pressure, there will be hyperperfusion and shock. There will be lack of blood as well as oxygen, so leading to shock. So again, more in detail, I would like to explain stimulation. Sympathetic stimulation causes vascular smooth muscle to constrict, and parasympathetic stimulation causes vascular smooth muscle to relax and dilation. That is why here parasympathetic nervous system is unopposed. There will be increased vasodilation, and the patient experiences predominant parasympathetic stimulation that causes vasodilation lasting for an extended period of time, leading to a relative hypovolemic state. So this will again result in hypotension. Blood volume is adequate because of vasculature is dilated. The blood volume is displaced and producing hypotensive and low BP status. And again, it will affect the cardiovascular changes. Overriding of parasympathetic stimulation that occurs with neurogenic shock causes a drastic decrease in patient systemic vascular resistance and bradycardia. At the end stage, we can see insufficient perfusion, inadequate blood pressure results in insufficient perfusion of tissues and cells that is common to all types of shock. So what are the signs and symptoms of neurogenic shock? There will be hypotension, bradycardia, bradyarrhythmias, flushed warm skin that gets cold and clammy later, lips and finger nails that look blue, lack of full consciousness. On physical examination, we will detect bradycardia, hypotension. Oculothermy means it is an alteration in the temperature. Hypothermia or hyperthermia both can be present, causing a flushed appearance, warm, dry skin from vasodilation, and flaccid paralysis below the spinal injury level. Flaccid paralysis mainly may affect one or more limbs, but most commonly it is affect the lower limbs because it is a lower motor neuron disease. The reflexes are also absent and muscle wasting we can see, and these muscles may be very tender and muscle spasm in the early stages. What is the management? Objectives of neurogenic shock management: implement evidence-based protocols, including hemodynamic stabilization, fluid resuscitation, and vasopressor therapy in individuals presenting with neurogenic shock. Selection of appropriate pharmacological agents such as vasopressors to manage blood pressure and restore vascular tone in neurogenic shock patients. Collaboration with specialists from the multidisciplinary healthcare team in providing comprehensive care for the patient with neurogenic shock. Immobilization: if the patient has a suspected case of spinal cord injury, a traction may be needed to stabilize the spine to bring the proper alignment. Administration of IV fluids is done to stabilize the patient's blood pressure. Pharmacological therapy, drug administration to undergoing patient with neurogenic shock are inotropic drugs, mainly the dopamine, may be infused for the fluid resuscitation. Atropine, again given to manage the bradycardia. Steroid patient with obvious neurological deficit can be given IV steroids such as methylprednisolone in high dose within 8 hours of commencement of neurogenic shock. Heparin to prevent thrombus formation. So low molecular weight heparin is administered most of the time. And moving on to the nursing care plan and goals. So I'm going to stress more on the nursing aspects. So the first thing, as a nursing care plan, we are focusing on maintaining adequate ventilation as evidenced by absence of respiratory distress. So airway management, mainly suction as necessary and document the quality and the quantity of secretions. If the cuff is ineffective, suctioning may be needed to remove the secretions, to enhance the gas exchange and to reduce the risk of respiratory infections. Very important note here, routine suctioning increases the risk of hypoxia and bradycardia as well as vagal response and tissue trauma. Therefore, suctioning needs are based on the inability to move the secretions or patient is unable to put out the secretions. Administer oxygen by an appropriate method depending on the nasal prongs, mask or intubation or ventilator support. The method is determined by the level of the injury, degree of respiratory insufficiency, and amount of recovery of respiratory muscle function after the spinal shock phase. Improving physical mobility. Reposition and turn the patient periodically. Continually assess motor function as spinal shock or edema resolves by requesting the patient to perform certain actions such as shrugging the shoulders, spreading fingers, squeezing, releasing the examiner's hand. Measure the blood pressure before and after every activity in acute phases or until stable. Change position slowly because of orthostatic hypotension may occur as a result of venous pooling, secondary to loss of vascular tone. Side to side movement or elevation of the head can aggravate hypotension and cause syncope. So it's very important to monitor for orthostatic hypotension. Inspect skin daily, observe pressure areas, and provide meticulous skin care. Patient education, teach the patient to inspect the skin surfaces, to use a mirror to look at hard to see areas. Altered circulation, loss of sensation, and paralysis potentiate pressure sore formation. This is a lifelong consideration. This can be a education once patient is about to discharge or to go home. It is a can carry this education message once they are discharged from the facility so that they can monitor themselves at home. Promote effective urination, promoting effective urinary elimination and improving bowel function. Assess the voiding pattern, mainly the frequency and the amount. Compare urine output with fluid intake. Palpate for bladder distension and observe for overflow. Observe for cloudy or bloody urine or foul odor. Dipstick urine as indicated. Encourage the fluid intake as per the recommendation, helps maintain the renal function and prevent infections and the formation of urinary stones, renal calculi. Note that fluid may be restricted for a period during the initiation of intermittent catheterization. So begin bladder training per protocol when appropriate. Fluids between the certain hours, digital stimulation of trigger areas, contraction of abdominal muscles and Cradis maneuver. Mainly putting the pressure on the lower abdomen to empty the bladder. Cleanse the perineal area and keep it dry. Provide catheter care as appropriate. Patients with spinal cord injury are at increased risk of constipation due to the disruption of neural pathways that control bowel function. Auscultate bowel sounds, noting location and characteristics. Observe for abdominal distension. Note reports of nausea and onset of vomiting. Check vomitus or gastric secretions. If the tube is in place and stool for occult blood. Record the frequency and characteristics and the amount of stool. Establish a regular daily bowel program, digital stimulation, prune juice, warm beverages, use of stool softeners, suppositories, enemas, at set intervals, determine the usual time and the routine of post-injury evacuation. Encourage a well-balanced diet that includes bulk and roughage and increased fluid intake, at least 2000 ml per day, but it will be as per the doctor's order. If there is any fluid restriction, strict intake output chart has to be maintained. Consult with the dietitian and nutritional support team for the further management. Recognizing and managing autonomic dysreflexia. Patients with SI injuries are at risk of developing autonomic dysreflexia, a potentially a life-threatening condition due to the disruption of autonomic reflexes that regulate the blood pressure and other bodily functions below the level of injury. So nurses must closely monitor the patients with spinal cord injuries for the signs and symptoms of autonomic dysreflexia and implement appropriate interventions promptly. Identify and monitor precipitating risk factors like bladder and bowel distension or manipulation, bladder spasm, stones, infections, skin and tissue pressure areas, prolonged sitting position, temperature extremes. Observe for any signs and symptoms of syndrome such as changes in vital signs, paroxysmal hypertension, tachycardia or bradycardia, autonomic responses like sweating, flushing above the level of the lesion, pallor below the injury, chills, nasal stuffiness, severe pounding headache, especially in the occipital and frontal regions. Note associated symptoms like chest pain, blurred vision, nausea, metallic taste, Horner's syndrome, contraction of the pupils, partial stasis of eyelid. So, and sometimes loss of sweating over the one side of the face. So these are the some of the signs and symptoms and the triggering in case of we have to, if in case of patient is experiencing autonomic dysreflexia, so we have to monitor for these signs and symptoms. Early detection and immediate interventions are essential to prevent the serious consequences and complications. Average systolic blood pressure in a tetraplegic patient is 120 mm of Hg. Therefore, reading of 140 plus may be considered as high. So, monitoring blood pressure frequently every 3 to 5 minutes during an autonomic dysreflexia and take action to eliminate the stimulus. Continue to monitor the blood pressure at intervals after the symptoms subsides. Elevate the head end of the bed at the 45-degree angle or place the patient in a sitting position. Lowers BP to prevent intracranial hemorrhage, seizures, or even death. Note, placing a tetraplegic in a sitting position automatically lowers the BP. So always it is important to monitor the patient's blood pressure. Any drastic movements can bring the blood pressure suddenly down and can have severe hypotension. Eliminate the causative stimulus as able such as bladder, bowel, and skin pressure, including loosening tight leg bands or clothing, removing abdominal binder or elastic stockings, temperature extremes, monitor for any alteration in the temperature. Enhancing effective coping and self-esteem. Patients with spinal cord injuries and neurogenic shock may experience grief and low self-esteem due to the significant impact of the injury on their physical and emotional well-being. Identify the signs of grieving, shock, denial, anger, and depression. Note lack of communication or emotional response, absence of questions. Shock is the initial reaction associated with overwhelming injury. Primary concern is to maintain life and patient may be too ill to express feelings. Provide simple, accurate information to the patient regarding diagnosis and care. Be honest and do not give false reassurance while providing emotional support. Assist patient to verbalize feelings about the situation, avoiding judgment about what is expressed. Note comments indicating that the patient expects to walk shortly and is making a bargain with God. Do not confront these comments in the early phases of rehabilitation. So focus on the present needs, mainly range of motion exercises and skin care. Patient education. Comprehensive neurogenic shock and its implication is a paramount for individuals who have sustained spinal cord injuries. Education is the most important thing to the patient as well as families. And in the families, some of the critical points: prevention and management. Patient should be aware of the strategies to prevent neurogenic shock, including staying well hydrated, minimizing abrupt movements, and adhering to prescribed medications. Emergency response educate on how to respond during the episodes of neurogenic shock, which includes lying down, elevating their legs, and promptly seeking medical assistance. Long-term consideration, patients should be informed about the enduring effects of neurogenic shock and its influence on daily life. Hence, addressing any concerns regarding lifestyle adjustment, rehabilitation, and ongoing medical care is crucial. Complications and follow-up. Patients should be provided with comprehensive education on potential complications of neurogenic shock, such as autonomic dysreflexia, emphasize uh, should be placed on attending regular follow-up appointments with healthcare practitioners, as well as compliance to the medication. Support and coping. Patients should be offered access to resources such as support groups, counseling, and mental health services to assist them in coping with the challenges of neurogenic shock and spinal cord injuries. As a summary of the topic, rehabilitation in patients with spinal cord injuries or neurogenic shock should be comprehensive, interdisciplinary, and patient centered, with goals that are individualized and realistic. Neurogenic shock can persist for approximately 1 to 6 weeks after the initial injury, certainly long enough to interfere with rehab in some cases. In addition to that, patients with spinal cord injuries are vulnerable to a number of cardiovascular complications which should be anticipated in the course of rehabilitation, and some with the prolonged or severe bradycardia may require permanent pacemakers. So, cardiovascular complications are the leading cause of morbidity and mortality in patients both in the acute as well as chronic stages of spinal cord injuries. So, common complications include autonomic dysreflexia, orthostatic hypotension, and reduced cardiovascular reflexes, and absence of cardiac pain during ischemia. I hope this topic is clear to you, and thank you so much for your patient listening. Have a nice day.